Chapter 72 is covering caring for clients with dementia and thought disorders. Please take a moment and stop this presentation to review the detailed learning objectives for this presentation. We are calling the mental activity in medical terminology as mentations, and changing of mentation can happen at any time during our life cycles. And definitely those will involve what is called the cognitive functions. As examples of those will be the short-term memory or the learning ability, and obviously they decrease in abilities as a person gets older and older. They may as well be acute or chronic, reversible or irreversible. So in other words, the older adults have a greater risk of having a certain degree of cognitive impairment, yet do not fall into this pit of thinking that reducing the cognitive capacity or the cognitive functions are a normal consequence of aging. And also do not think that the fact that we have diminished or someone has diminished cognitive abilities, that is obviously untreatable. There are other conditions that are totally treatable that may manifest with a certain degree of cognitive impairment. And as an example, that can be depression or hypothyroidism. So in other words, whenever there is a sign, there will be signs or symptoms of cognitive impairment, we need to have an aggressive and very focused assessment in order to understand if there is no underlying condition that can be treatable and can solve the cognitive impairment. Question number 1. Is the following statement true or false? Mentation changes only occur in advanced age. The answer is false. Mentation changes can occur anytime in the life cycle, and there are some associated medical conditions as depression or hypothyroidism that can manifest themselves sometimes as the first sign as cognitive dysfunction. We'll discuss now two of those elements that are most commonly encountered as defining elements of cognitive impairment, and those will be the delirium and dementia. And we'll start with the delirium. Delirium can be defined as a sudden and transient state of confusion. And the length of the confusion will always be related to the cause of the delirium. In a state of delirium, your client has an impaired capacity of processing information. They may show up disoriented as for the date, time of the day, or location. They may have impaired judgment. They may be unable to perform any type of intellectual activities, definitely not at the level that they did it in the past. They may show up and manifest as very suspicious or frightened or have inappropriate behaviors. There are some elements, some conditions that may manifest with delirium. Some may be high fever, head trauma, brain tumors, drug intoxications, and in some cases even drug withdrawal. There are a wide range of metabolic disorders that manifest themselves with delirium as liver or renal failure. They may be inflammatory processes, disorders at the level of the central nervous system as meningitis or encephalitis. And by treating those causes, by treating the underlying medical condition, delirium will resolve. Let's define now dementia. Dementia is most commonly seen in older adults and is defined by a continuous and progressive decline in memory, thinking, and reasoning, up to a point that it becomes severe enough that will affect the daily life of any person that is alert. And there is a wide list of conditions that manifest themselves as in the dementia spectrum. We have the Alzheimer disease, and we may have the Parkinson disease. And I would like now to take a moment and compare and contrast dementia and delirium. let's look at the onset. And if the delirium onset is sudden, it happens in minutes. Dementia develops gradually, and you see a gradual and persistent decrease in the abilities. The presentation of delirium, the presentation of the clients is that they are inattentive and blunted, while in dementia, they are just the opposite. They are attentive, they are alert, they just cannot process the information the same way, not at the same speed, not at the same depthness that they had before. How is the course of those two conditions compare? The course of delirium is very unstable with fluctuations. They are jumping from one state to the other. They may cry now, they may be happy now. It's very unstable. While the dementia, they are stable, and you can observe in them a progressive deterioration over time. The duration of delirium is very brief and temporary, while the duration of dementia is just the opposite. It's extended. It's almost a permanent condition. There are some differences in treatment as well. While the treatment is very specific in delirium because we are treating the underlying conditions that are generating the delirium symptoms, in dementia, the treatment is only symptomatic or supportive, and we are trying just to maintain the actual state and prevent future deterioration. The outcome for delirium is curable. Once the delirium cause is treated, the delirium symptoms will disappear, while the outcome for dementia is not treatable, is incurable. Let's discuss now about Alzheimer's disease. So Alzheimer's disease is probably the most common cause of dementia, and it can be defined as a progressive and deteriorating brain disorder. We have two types of Alzheimer's disease. One that is called the early onset, and obviously the onset, the development, first signs of Alzheimer's disease will be seen in individuals between 30 and 60 years of age. And we have what is called the late onset, that the signs and symptoms will start to show up after age 60. And definitely this late onset is the most common type of Alzheimer that we see. From the statistics in 2016, we had almost 5.5 million Americans living with Alzheimer's disease, and it is estimated by 2030 that the incidence will increase to almost 8 million. Now let's define a little bit the pathophysiology and etiology of the Alzheimer's disease, and let's look first into the early onset condition. So we know by now that having a first relative with Alzheimer's disease will double your chances of developing this condition as well. And we know that there are some mutations in some genes located on specific chromosomes 1, 14, and 21. Then as a result of those mutated genes, there will be a disruption in the production of a substance that is called an amyloid precursor protein. This amyloid precursor protein is called a transmembranous neuronal protein. It means that this protein sits in between the outside and the inside of the neuron, with a part of it being just in the middle, inside the membrane of the neuron. Now, there are two cellular enzymes. One is on the outside, one is in the inside of the neuron, that are able to cut those parts that are projected either inside or outside the membrane, and they will live behind the middle part of this amyloid precursor protein. And that part that is left behind is a starchy protein that will be situated just inside the membrane, and it's called beta amyloid. Beta amyloid will injure the neurons surrounding the development of this plaque. They develop as plaques, and especially the neurons that are situated in areas that are producing acetylcholine, which is an essential neurotransmitter for development of memory and cognition. Now, in the late onset of Alzheimer's disease, we know that the genes have a component here as well. However, they are not the most important ones, because there are elements of the environment and the lifestyle that can contribute as well in development of the condition later in life. Regardless if the condition is early onset or late onset, we know that the decrease in size of the cerebral cortex in the hippocampus is the result of acetylcholine deficiency and an increase of another a neurotransmitter that is called glutamate, which is in fact toxic. And all those changes will in fact explain the cognitive deficits and the changes, alteration in emotions that are seen in patients having this condition. Question number 2. Is the following statement true or false? Alzheimer's disease presents in 2 forms. The statement is true. Yes, Alzheimer's disease presents in 2 forms. The early onset presents before 60 years of age, while the late onset after 60 years of age. Late onset, definitely more common, with nearly 30% of all the adults older than 85 years of age will have manifest at a certain point some signs and symptoms of Alzheimer's disease. Let's look now into the assessment findings and what will be the signs and symptoms of Alzheimer's disease. So the progression will be from stage to stage, and the speed of progression will be completely different in different patients. One common element for all Alzheimer's disease patients, the onset is very insidious, and symptoms may develop extremely slow over many years. And it's known now that some of the very early signs of Alzheimer's disease, it will be a poor sense of smell. So let's look into the 3 distinct stages that were described for Alzheimer's condition. We have a stage that is called preclinical. It's a period when those amyloid plaques, remember that substance that accumulates at the level of the brain, will continue accumulating, and there will be some changes and the nerve cells will be damaged. However, there are no clinical signs yet. The next stage will be the mild cognitive impairment. Is that time when there are some memory problems. They are noticed both by the patients and by their environment. However, they are not serious enough to interfere with their independent living. And we have the stage that is called the Alzheimer's disease stage per se. It's that point at where there will be significant cognitive decline. The patient will have difficulty recalling words or learning new information, will have difficulty recognizing even familiar faces. The reasoning of the patient will be impaired, the judgment will be impaired, and definitely they have an incapacity of solving problems. We know by now that the memory loss is a classic symptom, and the memory loss is confined to receiving and storage of recent information. In times with the development of the condition, however, the condition will progress into long-term memory issues. The clients will have disturbances in behavior, they will have personality changes and depression. They may wander and become lost because they do not recognize the environment. They may have incidents of violent behavior. They may have issues with speaking, and that can be called aphasia, with reading, alexia, writing, agraphia, and calculating, acalculia. So all those elements, speaking, reading, writing, and calculating, can develop. They may not be able at a certain point to recognize even familiar objects or sounds, and this is called agnosia. It can be visual, tactile, or auditory. So they may not recognize something by seeing them or by listening to them. However, if they are feeling, if they are touching that object, it still can be recognized, or all 3 elements can be affected. They may have a difficult walk. It's called ataxia. They may have tremor. They may have an inability to accomplish any type of activities related to daily living, as grooming or toileting or even eating. So this is called apraxia. Let's look at the diagnostic findings. So ruling out Alzheimer's disease in clients that may have similar signs and symptoms it's essential. And this is because it's a very complicated diagnosis, and patients and families can go through a turmoil just thinking that their loved one may develop Alzheimer's disease right now. So to say that a patient has Alzheimer's disease, we are actually doing what is called an exclusion diagnosis. We first of all go and look into any kind of objective physical conditions that can manifest with the same signs and conditions in order to rule them out. And only after we rule out all those other conditions, we can put the diagnosis of Alzheimer. We will perform a computed tomography, and when doing that, we can observe a shrinking of the cerebral cortex. However, if it's an incipient stage, if it's at the stage of a mild cognitive impairment, that not be extremely evident. We can perform a PET CT or an MRI, and again, those can provide both structural and metabolic information about the brain. When performing an EEG, an electroencephalography, we can see slower than normal brain waves. Again, none of them are specific for Alzheimer's disease. And that's why we need to make sure that we rule out any other conditions. We can look into diagnostic tests that can detect biomarkers or proteins in blood or the spinal fluid that can be the markers for neurodegeneration or the destruction of the neurons. Once a diagnosis is performed, we need to manage the condition. And we'll discuss now the medical management. We need to emphasize from the beginning that there is no cure for Alzheimer's disease, and the treatment is what we call supportive. And we are trying to support the existent function and prevent future deterioration. We are trying, by doing that, to maintain the patient's independence in their familiar environment as long as is possible. As long as the client is safe and there is not a lot of burden on the primary caregiver, that usually will be the spouse. The moment that that point has been gone and the patient is not safe in their own environment, we can look into other options. In terms of drug medication, there are 6 drugs that are currently approved by the FDA for the treatment of Alzheimer's disease. And those are cholinesterase inhibitors as Aricept, donepezil, rivastigmine, Exelon, and Rezidine, which is galantamine hydrobromide, memantadine, Namenda. There may be there is another product that is a combination of memantadine and donepezil, which is Nameric. All those drugs, with the exception of memantadine, will increase the acetylcholine by inhibit the enzyme that will destroy the acetylcholine at the level of the synapses by inhibiting the acetylcholinesterase. Memantadine, Namenda, has a different mechanism of action, and this is because it has a neuroprotective mechanism. It is classified as an N-methyl D-aspartate antagonist. Namenda is blocking NMDA receptors, and as a result of that, will protect the neurons from the excessive stimulation by glutamate. Remember that I was telling you that glutamate accumulates in the brain tissue? Well, when it accumulates, glutamate is an excitatory neurotransmitter. And by hyperstimulating and hyperexciting the neurons is causing neuronal death. Memantadine is blocking those receptors. Therefore, the glutamate that is in high quantities at the level of the brain of an Alzheimer patient will be blocked. We can use other categories of drugs as well. We can use antidepressants or tranquilizer whenever we need to deal with an agitated or depressed patients. We can use valproic acid, Depakote or Valproat, that usually we are using that for seizure disorders. However, it's been shown that valproic acid is very efficient in agitated patients with Alzheimer's disease. There is another medication that is called Axona. that is a medium chain triglyceride product. And because of that, it's called a medical food. And it's used as a co-therapy for the treatment of Alzheimer's disease, based on the fact that there will be a metabolic dysfunction at the level of the brain in those type of clients. Um, the metabolic dysfunction will be an inability of the neurons to utilize glucose for energy, somehow in some way similar to what we see in a diabetes mellitus. There will be an impaired usage of fats. There will be a reduced production of acetylcholine, and all those will interfere with the clearance of those amyloid producing proteins. So what Oxona is doing, it's an oral product that can be taken by mouth, orally, and is metabolized into ketones. And as a result of that, there you go, you have an easy source of energy for the brain as an alternative to the glucose, which seems to be harder for the neurons to use in Alzheimer patients. What do we do in terms of nursing management? Well, the major focus for Alzheimer patients is to help them, and as well the caregivers, to maintain the highest possible quality of life by offering both physical and mental support, along with ensuring that they are safe in their homes. So you'll see that most of those clients will receive care at home for as long as possible, and when not possible anymore, they will go in a system, in a healthcare house where they will be taken care of. A big emphasis needs to be on the client's nutritional needs, and especially when those are living alone, we need to make sure that the nutrition is ensured at the level that is needed. Question number 3. Is the following statement true or false? The goal for Alzheimer's disease treatment is to place the client in an extended care facility as soon as possible to maintain his or her safety. The statement is false. The goal for an Alzheimer's disease treatment is to maintain clients' independence as long as possible in their familiar surroundings, definitely based on the available caregivers and the finances of each of those patients. A careful assessment is continuing for client safety and the caregiver burden. A second type of condition that involves cognition is schizophrenia. And we define schizophrenia as a thought disorder that is characterized by a deteriorating mental function, disturbances in the sensory perception, and changes in the emotions or affect. In other words, the clients with schizophrenia will show improvement with drug therapy. However, they will never fully recover. And the condition is lifelong and in most cases appears in a young adulthood age. It's a condition that will cause a lot of anguish for the families that need to deal, keep in mind, both the burden of healthcare costs and the responsibility for caring for someone that needs to deal with this illness. Let's look into the pathophysiology of this condition. So back in the day, schizophrenia was considered to be an emotional dysfunction. Now we know that it is actually a psychobiologic condition. And this because now we are able to understand how the brain and the neurotransmitter chemistry works. There are a lot of neurotransmitters that are imbalanced in a patient with schizophrenia. There is an excess of dopamine, too much dopamine, and this seems to be the major cause of the symptoms. There are imbalances of norepinephrine and serotonin and gamma-aminobutyric acid. Schizophrenia is known to have a genetic component to run in families. There are some theories that suggest that there can be an anatomic and, as a result of an anatomic, a physiological change associated with schizophrenia as a result of a viral infection um, experienced by the affected individual's mother during pregnancy. In other words, what I was trying to say is that there is a theory that says that if the mother had a viral infection, without saying which type of viral infection, any type of viral infection that will pass through um, the placenta during the pregnancy to the infant during the stages of development of the nervous system, that can create some anatomical changes that later in life will cause schizophrenia in that individual. As a result of those neurochemical imbalances, we'll see signs and symptoms as delusions. A delusion is a disturbed thinking. And the themes of the delusions can be suspiciousness or persecution, that someone controls them. They may have grandiosity. They believe that they are very important. They may have religious fixations or a preoccupation with sex, love interest, illness, or a body part. They may have hallucinations, and hallucinations that are a sensorial experience that only the client is perceiving that. Most of the time they are auditory, but sometimes can be visual as well. Let's look at the assessments. So the first symptoms usually will develop during late adolescence and early adulthood. There will be a range of symptoms that we define them as positive or negative. Positive is when we see them and they are additions to what it's normal seen in someone's behavior. That's why I call it positive. And negative are those symptoms that are inexistent. We would like to see some emotions or some elements or behaviors, and they are inexistent. And because of that, we are calling them negative symptoms. So the positive symptoms will be added things as delusions, hallucination, and the speech that it can be fluent, however, is totally disorganized. It doesn't make sense. The negative symptoms are also called defect symptoms. Will be impoverished speech and speech that is very limited, an inability to enjoy any type of relationship, or inability to express emotions. So I will give some examples of the negative one. They will have a very concrete thinking, like a child. They will have a literal thinking instead of a symbolic one. They will have an inability of understanding abstract ideas. They will have a thought blocking, an inability to recall information for a time. They may have what is called symbolism. They will attach a certain significance to something that in fact is an insignificant object or idea. They can show a blunted or flat effect. No display of feelings or very little display of feelings. They may show up with catatonia, which is immobility, total immobility, or as a variation of that, posturing. They will assume statuesque positions, like very imposing positions, and not move out of them. They may show with anhedonia, which is an inability to experience pleasure. They may have signs of autism, which is defined as a social withdrawal, will neglect hygiene, eating, work, finances, will be completely detached from their normal environment, and they will have, in some patients, there will be a poverty of thoughts. Thoughts will be lacking, or they will have no opinions or idea. On the other hand, let's give a few examples of the positive symptoms. Besides the delusion and hallucination, they may have what is called loose association. They may speak and present a sequence of ideas that are only slightly connected. They may show inappropriate affect. They will display emotional feelings that are inconsistent with the existing situation. They may show up with echolalia. They will repeat what other people are saying continuously. They may speak in rhyming. They may have what is called a word salad. They will just use unrelated words in one sentence. Or they may invent new words, and that is called a neologism. They may show up with repetitious movements. This is called a stereotypy, or will mimic the movements of the people around them, and that is called echopraxia. In a discussion with a patient with schizophrenia, they may exhibit tangentiality, which is a digression from one topic to the other very quick. Or they can show circumstantiality. They will digress from one topic to the other, but return back to the original topic over and over. Now, going back to the signs and symptoms, the classic symptoms will be this inexplicable sensory experiences. They will hear voices, they will see apparition of people, and this will occur in combination with very awkward, peculiar patterns of speaking or very awkward motor behaviors. Hygiene and appearance tend to lack. The patients may abandon relationship and interactions with others, will have no interest in, show no interest in work or school. They will have no goal-driven behaviors. In terms of diagnosis, the diagnosis is made primarily based on the symptomatology, and by ruling out other causes, we will perform a CT scan or MRI in the brain mapping in order to identify that there are no other causes that can determine this behavior on the side of the patient, like tumors or infections. What will be the medical management for schizophrenia patients? The main care of this type of patients will be the job of a psychiatrist. We will try as much as possible to not have them institutionalized. There will be an exception, however, if a patient is dangerous to self or the other. There will be community mental health services in their community that are able to meet the client's needs in terms of psychotherapy and drug administration, social needs. Those patients will need help with housing, sometimes job assistance, and help with money management. Looking into the drug therapy, we can give those patients antipsychotic drugs that are the main line of medication used in the treatment of schizophrenic patients. They are called, another name for the antipsychotic is the major tranquilizer or antipsychotic or neuroleptics. So they belong to different chemical families. However, they have one thing in common. They will all block receptors for dopamine. Remember, all those conditions have in common a very high level of dopamine. So newer antipsychotic drugs will block dopamine receptors, and some examples of those are in the category of typical antipsychotic drugs as Haldol or Prolixin, Risperidol, or Zyprexa. One thing regarding risperidone, clozapine, and olanzapine, all of those produce their effects by reducing the incidence of extrapyramidal symptoms. And those are the movement disorders that are associated with traditional antipsychotic. And that's why we prefer those second generation antipsychotic as opposed to the first generation. And the first generation were Thorazine, Haldol, all those first generation conventional antipsychotic drugs. There are some potential adverse effects that can be even dangerous, and they are seen with clozapine that can depress the bone marrow function. That's why in patients with clozapine treatment, we'll need to have a weekly and sometimes a bi-weekly blood count. And whenever the white blood count drops too low, the drug needs to be discontinued. Anticholinergic drugs, such as Artane or Cogentine, are given to prevent or relieve the extrapyramidal symptoms seen mainly with the conventional antipsychotic drugs. And in some cases, the antipsychotic can be combined with anticonvulsant drug, such as clonopin or Tegretol. A big issue related to the medication of schizophrenia patients, and it's seen widely in the mental health um, area, is the non-adherence to drug therapy. And by non-adhering to the drug therapy, there is a high incidence of return of the symptoms and the need for short-term hospitalization. Because of that, and trying to prevent this from happening, there were developed, the manufacturer developed depot injections that are IM injections with antipsychotic, with the same antipsychotic drug. However, it is suspended in an oil support fluid that allows for gradually absorption. And those depot injections are given every 2 to 4 weeks in order to prevent the showing up of the signs and symptoms when the patient is not taking the medication anymore. In terms of nursing management, it's essential that the nurse will address mainly beside the assessment and diagnosis and planning, in terms of intervention, is to evaluate the safety of the environment of the patient, make sure that the patient adheres to the treatment, and whenever the treatment is not administered as it's supposed to be, to recommend maybe the administration of depot type of products. In addition to that, the nurse will need to be aware of any type of side effects that can be the result of the condition or the treatment, the medical treatment. One of those conditions is called tardive dyskinesia. And tardive dyskinesia is an irreversible reaction, especially seen in the typical antipsychotic medication, the classic, the conventional one, the first generation. And the tardive dyskinesia is manifested by rhythmic, involuntary movements of the tongue, face, mouth, jaw, or extremities. Those need to be reported immediately to the provider, because they can become permanent and impair the daily activity of a patient.